Namaste. This is week number 8, lecture number 6. Today I am going to speak about recent advances in management of nausea vomiting. We have already studied the symptoms of nausea vomiting under gastrointestinal symptoms, but again I am going to repeat it, as this is very important symptom which needs to be managed sometimes by palliative care physician. Almost over 80% of our patients are on chemotherapy, either a curative chemotherapy or palliative chemotherapy, and they are likely to get nausea and vomiting, which is a usual side effect of any chemotherapeutic agent. Even patient on radiotherapy, receiving radiotherapy, they are also likely to have nausea vomiting. So, these patients many a time they attend chemotherapy and radiotherapy department as well as palliative care department. So, when they come to us, it is our moral duty to do symptom management, or sometimes patients are referred to palliative care physician for symptom management, and nausea vomiting is the predominant symptoms in a group of patients who are attending palliative care OPD, and that is why we are revising this subject to some extent and going to have few new drugs studied in this lecture. Nausea vomiting is a common symptom in 40 to 70% of the patient, and there is a evidence that it is highly underappreciated problem or undermined problem and not attended adequately. So, during 1990 the selective 5-HT receptor antagonists were first introduced for the treatment of chemotherapy induced nausea vomiting, this CINV. And since then significant progress has been made in last 15 years in developing more effective and better tolerated measures to minimize chemotherapy induced nausea vomiting. And because of these drugs, it has become very easy to administer chemotherapy as patients tolerate chemotherapy well and compliance to the treatment has increased. The nausea vomiting has got a many deleterious effect on the patient's body. It will cause metabolic derangements, sometimes hypoglycemia, sometimes dehydration, sometimes hyponatremia, and which are very frustrating symptoms to attend. Second is malnutrition, esophageal tear, retching, very vigorous retching against closed glottis can cause tear in the esophagus, fractures and wound dehiscence, unrelieved nausea vomiting following surgery can cause wound dehiscence, the sutures to rupture. So, severe side effect can lead to non-compliance, patient will refuse the treatment, next time मुझे chemotherapy नहीं लेनी है और अभी मुझे रेडियोथेरेपी के लिए नहीं जाना है. These are the common things you will find if his symptoms are not relieved. Then loss of time at work, additional consultation, multiple time they have to attend the hospital to relieve their symptoms, that will increase the cost of their treatment, disability and death can occur, and this all things will lead to poor quality of life in our patients. So, management involves accurate assessment. First of all, assess the symptoms, since how long patient has, how frequently nausea vomiting has, what is the severity, on 0 to 10 VAS scale you can judge the severity, then give treatment and again monitor and check the things. So, and one should have a good knowledge of the all anti-emetic drugs which are available in our market. Consider route of administration, always not stick to oral route in this patient, because they are already vomiting and they will not tolerate extra pills you are going to give to this patient, and control of symptoms is possible only in 60% of the patient. This was already discussed in previous lecture, that following chemotherapy patient can have various types of nausea vomiting, which can be first of all it can be acute, which occurs within starting of chemotherapy, within few minutes of starting of chemotherapy and resolve within 24 hours. Another is delayed, which will occur after 24 hours and may last for 3 days, 5 days or 7 days. Breakthrough nausea vomiting. Though patient's nausea vomiting is controlled with one set of drug, antiemetic drug, but intermittently he or she may get 1 or 2 bouts of nausea vomiting in a day. That is called breakthrough nausea vomiting. Refractory, this type of nausea vomiting is unmanageable with current antiemetic regime you have, and anticipatory, sometimes conditioned. As soon as patient enters the chemotherapy ward, he will get nausea vomiting. So, these are the various types of nausea vomiting found in our patients who are taking chemotherapy. The steps in management starts with establish the likely cause, identify the most likely pathway, whether it is arising from the stomach or from the labyrinth or from the higher centers. See which receptors are involved, choose the most potent antagonist, choose the most appropriate route of drug administration, review after 24 hours. If it is still not cured or relieved, add another drug. Opt for regular rather than PRN doses. Always give this medicine regularly, means 4 hourly or 6 hourly or 8 hourly, rather than PRN dosing, means as and when required. It is not done like that. Initially it has to be on regular dose schedule. Titrate the drug dose accordingly, and reassurance of patient and family is very important. Keep in mind, one single antiemetic may not work, you have to give multiple drugs. Like multiple cause may require combination, like for raised intracranial pressure or uremia, you may need to have give dexamethasone, haloperidol and metoclopramide. Persistent vomiting, always secure a cannula in subcutaneous route below the skin, and keep in mind the extrapyramidal system whenever you are using metoclopramide like drug. So, chemotherapy induced nausea vomiting occurs because of the stimulation of the CTZ, that is area in brain, and then stimulation of the vomiting center into the brain. Another way is it stimulates the gastric mucosa and releases 5 HT3 receptors, and these receptors are stimulated, which in turn will stimulate vomiting center and it will cause nausea vomiting. The nausea vomiting found in chemotherapy, patients who are receiving chemotherapy, can be of level 1, means only less than 10% of the risk, level 2 where the risk of nausea vomiting is 10 to 30%, level 3 with the risk of nausea vomiting 30 to 90%, and very high risk is level 4, more than 90%. So, here they have given the number of drugs which are which will cause this type of vomiting, chemotherapy drugs. So, whichever chemotherapy drug is given, you can have a anticipation which level of nausea vomiting will occur in this particular patient. So, patients mostly our patients are on carboplatin or cyclophosphamide, they are likely to have moderate risk of having nausea vomiting. So far available antiemetic drugs which we have are acts on dopamine receptor in CTZ, that is metoprolol, domperidone, butyrophenone and chlorpromazine. So, here in this you have to be very careful about extrapyramidal side effect, which in terms of maybe seizure, rolling of eyeballs and all like that, and dystonic reaction, acasthenia and sedation. With the new drugs, serotonin receptor antagonists, 5-HT3 receptor antagonists, which are present in CNS, central nervous system and GI tract. Here you can give ondansetron, granisetron or tropisetron and palanosetron, which acts on CNS and GI tract through vagus itself. One can give this drug with or without dexamethasone for acute and delayed chemotherapy induced nausea, vomiting, and these drugs are effective orally. That is the beauty of it, that you need not have venous access or parenteral infusion for this. The side effects are very mild headache, constipation or diarrhea. Polanosetron has got it is longer acting drug, so it has got a better control on nausea, vomiting, and dolasetron you have to be careful with the ECG changes it cause, like prolongation of QT interval. Cannabinoid receptors CB1 and CB2, Nebilone agonist has anti-emetic activity, but cannabinoid is not easily available and it requires particular license. Particularly it is sold under Ayush Ministry, so not available for the it is not FDA approved for medical use. Newer anti-emetic agents like neurokinin 1 receptor antagonist, this is substance P and neurokinin 1 receptor in anti-emetic pathway. The wonderful drug in this group of anti-emetic is aprepitant. It is given orally and it is given over 3 days. First day the dose is 125 milligram and repeat on second and third day 80 milligram. It is given prior to starting chemotherapy. So, it has got a wonderful anti-emetic effect and patient can tolerate chemotherapy very well. Which are the drug interaction with this drug? They are moderate inhibitor of the CYP3A4 enzymes, should not be administered with the pymazide, cisapride, cyclosporide, and dose of dexamethasone should be half whenever you are using aprepitant, and rifampicin will reduce concentration aprepitant. So, rifampicin should not be given to the patient on that particular day. A clinical trial which in which assess the effect of aprepitant on drug metabolizing enzymes recommended a 50% reduction in oral dose of benzodiazepines metabolized by CYP3A4 including midazolam and alprazolam. So, whenever you are giving the drug aprepitant, you reduce the dose of midazolam or alprazolam if patient is on given this drug for insomnia. These are the various drug and its dosage which is given along with aprepitant, like Dexona given 12 milligram along with 125 aprepitant on day 1, day 2 aprepitant 80 milligram, Dexona 8 milligram, day 3 80 and 8, and day 4 no aprepitant, it is given only for 3 days and continue your Dexona per oral route. Other drugs and techniques, sometimes patient may require antidepressant if they are on chemotherapy and having severe nausea, vomiting. You evaluate the psychosocial aspect, and if you find there is a element of depression, you can start antidepressant. Then gastric electrical stimulation in gastroparesis and surgical therapy. So, what is the incidence of nausea, vomiting in non-cancer disease also? Like it is common in AIDS patient, in chronic kidney disease patient, and even in COPD patient, and also in heart failure patient. So, these are the common non-cancer disease also where you will find nausea, vomiting common symptoms to deal with. Management again, like any other palliative care setup, it is non-pharmacological management, complementary medicine management, medical management and psychosocial evaluation. This the combination of whole, and you will be treating the patient as a with holistic care, then the outcome will be better. So, here we will discuss one case report. A 56 years old female diagnosed with cancer of ovary 5 years ago had undergone surgery and chemotherapy. She attends gynec OPD for nausea, vomiting, constipation and referred to Department of Palliative Medicine while awaiting for CT scan after 10 days. Her follow up CT scan is planned after 10 days. Meanwhile, he comes to gynec OPD and then he is referred to palliative care OPD, and she was admitted in palliative care bed as she was awaiting for the CT scan. On examination, it was found that there is a distension of the abdomen. The nausea vomiting score was very high, 7, means patient had severe nausea vomiting. Initially treated with IV fluid, metoclopramide and MSET. ESSA score was 3, so within 24 hours her nausea vomiting came under control and the score came down to 3 within 24 hours. Since she had constipation, keep in mind these symptoms is usually observed by palliative care team only. Then proctoclysis enema was given and stool was passed. On 5th day, her nausea vomiting worsened. It score went up to 7. Again there was distension. On auscultation there was peristalsis were present. Patient underwent Ryle's tube insertion and it was aspirated. That 500 ml of aspirant came out from the stomach, and patient also complained that she is not able to pass flatus from below. That means patient is developing malignant bowel obstruction. So, per rectal examination showed obstruction at 5 centimeter due to recurrence. Because of the CA ovary, there was a recurrence and it was pressing on the rectum, and that was obstructing the large bowel, and because of that she was not able to pass flatus, and she had distension of the abdomen because of that. And this obstruction could not be negotiated with the finger or any small cannula. So, again patient is treated with nil-by, she was kept nil-by mouth, put on IV fluid, she was given antiemetic till her CT scan was hastened up, it was taken up as early as possible, and on CT scan that recurrent mass pressing on the large bowel was found. So, she was advised to undergo colostomy. The obstruction was diverted and colostomy was performed. Her obstruction was relieved and her nausea vomiting also relieved. So, you have to keep the whole picture in mind whenever a patient may come with the smallest symptoms like nausea, vomiting or only constipation, but you have to keep the whole picture of the patient disease, previous disease and present status of the disease in mind and act accordingly. This way you can relieve the symptoms of the patient, make their life better and improve the quality of life. Thank you very much.